Right now we start. Good evening or maybe good morning, everyone. This is Forrest from Xiaoting Medical. Today, we are very honored and proud to invite Dr. Anthony David Holley to share with us his latest research. Before we start, let me introduce our special guest today, Professor Xiaoting Wang. He is the president of CCUSG, currently also the director of ICU in Peking Union Medical College Hospital. Professor Xiaoting Wang has more than 20 years rich experience in critical care medicine field. He received relevant training and certification at Harvard Medical College at 2009. After that, he participated in the compilation job of international guidelines for the application of critical care echocardiography. In 2013, Professor Wang and his colleagues established CCUSG, set up a complete training system of critical care ultrasonography, and also proposed a critical care training system based on critical ultrasonography. We saw Dr. Wang's face now.
Yeah, thank you. Hi, nice to.
Okay, in 2016, he and his CCUSG colleagues held the first Chinese academic conference on critical ultrasonography in Chengdu, China. After that, 4 annual conferences on critical ultrasonography were organized. Professor Wang was the earliest one to propose subspecialty and the subsubject of critical care medicine and emphasize the nature of subspecialty of critical ultrasonography in critical care medicine. Now let us welcome Professor Xiaoting Wang.
Hi, everyone. Every doctors, maybe the practitioners of critical care medicine, online, maybe offline. Thank you. Yeah, maybe it's my turn to introduce Professor Holley.
Not professor, doctor.
Doctor, okay.
Not professor, I can hope for that.
You are very nice. You are very nice. Okay. Maybe the Dr. Anthony David Holley. It's my honor. It's my pleasure. Maybe say many thanks to him, and many thanks to Virchows for organizing this beautiful event. It's my great pleasure. It's my honor being here to attending this webinar. And then now let me introduce today's speaker, Dr. I think Professor. Dr. Anthony David Holley. He is the president of Australian and New Zealand Intensive Care Society, and currently is also the eminent senior staff specialist intensive care medicine in Royal Brisbane Women's Hospital, and the senior lecturer of University of Queensland, the School of Medicine, and the supervisor of College of Intensive Medicine training in Royal Brisbane Women's Hospital, the examiner College of Intensive Care Medicine of Australia and New Zealand. The education team lead, Jameson Trauma Institute, and he is the member of College of Intensive Care Medicine Examiners Committee, Royal Brisbane and Women's Hospital Transfusion Committee, SCU Training Pathway Oversight Committee, National Blood Authority Critical Care Reference Group Critical, and the member of Australian and New Zealand Intensive Care Society COVID-19 work. It's a great work. great job. And then a member of COVID-19 critical care collaborative group. Dr. Anthony Holley is a senior specialist experienced to several medical segments, medical world, and especially specialized in field of emergency, intensive care medicine, etc. He got the Bachelor of Medicine and Surgery, University of Witwatersrand in 1991, Diploma of Pediatrics, Auckland University in New Zealand. Now is also the fellow of Australian College of Emergency Medicine, that is to see FACEM, as fellows of the colleagues of intensive care medicine and Australia and New Zealand with maternity background. He has been dedicated in medical field for almost 60 years. By far, he has got numbers of publications and reward on his credit. Now, let's welcome Dr. Holley. Maybe take a great lecture. I think it's our lucky. Hi, it's your turn.
Thank you very much, Professor Wang. It's a real privilege and an honor to be here. And I'd like to take the opportunity of thanking all the administrative staff at Xiaoting for the assistance and the great opportunity. And I'm looking forward to a very interesting evening and hoping that we generate a lot of discussion around a topic that I, for one, am fascinated with, and hope that everybody else shares that enthusiasm. So thank you very much, Professor Wang. Thank you very much, Xiaoting. And it's a very great privilege to be here. And I look forward to interacting with the members online tonight. So thank you very much. With that, I might try to share my screen and go to my presentation and hope that comes up. I'm just struggling to find it here. People bear with me, and I should show all windows. Let's see what else I can find. There we go. And we should now, if you just bear with me, we should now be able to open this very shortly. If I say share screen. Apologies, it's just not coming up. We did this earlier on and were able to achieve it. So with a bit of luck, we should be able to open this up.
Doctor, you have to open your presentation first and then to share the screen. So currently, I think you have to stop sharing the screen, then you go back to open first and then share the screen, steps like that, okay?
Okay, we'll give that a try.
Mm-hmm.
What
yeah,
I'll do,
yeah, no problem.
just try and open the presentation. Well, hopefully that'll work. Now we'll try and share the screen again. We did test this earlier on.
Mm-hmm.
And again, that's not coming up. Perhaps here, let's have a look, see. Yeah, that's looking promising.
Yeah. Then you can play it. You can play it. I think it's okay.
All right. Can you all see me there?
Yeah, we saw it now. Yeah.
Oh, fabulous. Look, so the first thing I have to do is declare any conflict or declarations. And I'm very grateful to Xiaoting for the honorarium they'll be providing for this presentation. So thank you for that tremendous opportunity. I think at this time in June 2020, it would be completely unreasonable to have a critical care presentation and not refer to the COVID-19 crisis. And these images, I think, ring very true with every critical care physician across the globe. If we consider in the top left-hand corner, if you consider in the top left-hand corner, mass graves in New York, the United States of America, who would ever have thought about that? A makeshift hospital made in Wuhan, China, to accommodate the massive numbers. And again, those other two images of an overcrowded intensive care in the United States of America and a Spanish patient being transferred in their very difficult circumstances. And I think I would just like to dedicate our discussion, our thoughts to our colleagues who have done it incredibly tough over the last 6 months, and our gratitude for the quality of work that they've done. So how big is the problem? If we're talking about, tonight we're going to talk about pulmonary embolism and deep vein thrombosis. And I think we need, first of all, to appreciate how big the problem is or it isn't. And I think if we take as a baseline, 1% of all hospitalized patients will develop a deep vein thrombosis. That in itself is a very significant figure. But if we look at patients that don't receive appropriate prophylaxis, that figure may jump as high as 80%. And that's a startling revelation, if you like. I think if we look at probably more worrying, patients that receive some form of thromboprophylaxis in the critical care setting, as many as 45% of those patients may in fact develop a deep vein thrombosis. And the concern obviously with deep vein thrombosis, aside from the complications related to the post-phlebitic syndrome and the issues surrounding that, is of course the issue of pulmonary embolus. And if we consider that probably as many as 3 to 12%, sitting somewhere in the order of 8% of patients will progress to a pulmonary embolus. And even more worrying than that is the notion that pulmonary embolism in this group of patients probably carries somewhere in the order of a 50% mortality. So these are very stark figures that should be saying to us as critical care physicians and critical care health staff that we should be paying attention to this problem. Put another way, if a patient survives the first 24 hours after major trauma, their third leading cause of death will be a pulmonary embolus. And again, I don't think there's a person in the audience that hasn't looked after patients that have done it very hard in the intensive care for many weeks on end, only subsequently to die of a pulmonary embolus. And this is what we as critical care physicians need to avoid through a range of strategies. Now, we've known about the notion of thromboembolism for the longest time. And in fact, it was Virchows in the very first instance, a fellow that was born in 1821, died in 1902. And in 1856, he was able to describe the notion or the concept of a thrombus forming in the peripheral venous circulation and subsequently embolizing to the pulmonary circulation. And it's interesting that Rudolf Virchow, in fact, was accredited with Virchow's triad, when in fact that was only described in the mid-1950s. So he was one of those fortunate people in the medical practice that got credit for something he in fact never described. But what we know of Virchows triad today is this concept of a coming together of several factors that put us at risk of deep vein thrombosis. And the first and foremost is stasis, and patients in the intensive care at bed rest are in a very challenging position whereby their circulation isn't moving as briskly, and therefore they're at risk of deep vein thrombosis. Additional to this, many patients in intensive care are deeply sedated or have neuromuscular blockade as part of their therapy. It's also now well recognized that the potential to become hypercoagulable in the intensive care as a function of your disease process or trauma process is very well recognized. And finally, we're becoming more and more familiar with the issues surrounding the endothelium and endothelial injury. We now have a far greater understanding of the endothelial glycocalyx and how relevant that is to coagulation. And in the setting of a damaged endothelium, be it secondary to sepsis or direct trauma or even toxin related, we now know that that sets patients up with this triad of endothelial injury, hypercoagulability, and stasis, and the very real risk of a subsequent thrombosis. This has interested me for quite some time. As a military officer, I've served overseas on multiple occasions. And on one of my deployments to Afghanistan, it became apparent to me that there was a huge number of patients. And I collected this data and unfortunately could never publish it because of the issues surrounding military clearance to publish something like this. But the reality was that we were able to identify a significant number of patients who had sustained severe trauma and, interestingly, developed pulmonary emboli within the first 6 to 8 hours of their injury. Now, admittedly, many of these pulmonary emboli were in fact incidental findings, and the relevance is difficult to ascertain. But what it does say is that very early on in the process of a patient being critically unwell, this disruption or this activation of Virchows triad, such that there's a coagulopathy, there's an endothelial injury, and there's stasis, sets the scene for subsequent pulmonary embolus. And this led myself and a colleague, Michael Reed, to review the literature and think about the procoagulopathy of trauma. And perhaps in a cruel sort of way, is this coagulation that we encounter too much and too late? Not precisely when the patient needs it, but further on down the track. And if we consider the normal hemostatic process requires a balance between procoagulant and anticoagulant activity, as well as requiring a balance between antifibrinolytic activity and fibrinolytic activity. And it's in that setting that we strike the balance between thrombus and bleeding, such that a patient who's bleeding generates a thrombus, and when the bleeding has been controlled or ceases, then the thrombus no longer continues to propagate or develop. And we hypothesized that in the setting of trauma, for example, but you could equally say sepsis, exists some degree of endothelial ischemia. And that endothelial ischemia is responsible in part for the coagulopathy that we encounter, which is so allied to the systemic inflammatory response, which in turn might take us on this continuum to the procoagulopathy over a period of time. So these poor patients move from bleeding through multiple organ failure and ultimately to thrombosis. And we probably enhance that process through our range of therapeutic interventions, which include a blood transfusion, platelet transfusions. We don't use as much activated factor 7 these days. prothrombin concentrate complexes, tranexamic acid, fibrinogen, or cryoprecipitate delivering fibrinogen, one of these preparations probably pushes these patients towards that procoagulant state. And so the challenge is finding this balance between thrombosis resulting in pulmonary embolus and deep vein thrombosis and the therapy that we institute in the form of heparin-induced thrombotic thrombocytopenic syndrome. And on the other side of that equation, we have that very real risk that we worry about the patient bleeding from surgical or trauma sites. And of course, we are very fearful of a central nervous system bleed. And indeed, again, these patients with heparin-induced thrombotic thrombocytopenic syndrome are at risk of bleeding as well as coagulation. So that's the challenge that we face. And in the coming few minutes, I'd like for us to touch on a couple of issues with respect to this. First of all, I'd love for us to have time to talk about the antithrombotic therapy for thromboembolic disease. And all I can do is commend these guidelines, the chest guidelines. The American College of Chest Physicians has published a remarkable set of guidelines that are evidence-based and very useful. You can pick them up on various podcasts. You can obviously pick them up in the supplementary to the Journal of Chest, but I'd strongly commend them to you, and they're a very worthwhile read. What we have in the chain of prophylaxis in terms of our armamentarium in the setting of the pathophysiology that I've just described and the risk for critical care patients to go on and develop a thromboembolic complication, we need to look at what's available to us. And in the first instance, compression stockings are potentially useful, pneumatic compression devices, chemoprophylaxis, and I've just made reference in that introduction really to the chest guidelines. And then I'd like to talk a little bit about inferior vena cava filters, something in which I find very interesting, and I think that it's still a very novel frontier. And something that's very intuitive, but surprisingly poorly executed in the critical care population is the concept of early mobilization of these patients. And underpinning all of this is the ability to diagnose a deep vein thrombosis, particularly in the asymptomatic, sedated, ventilated patient in the intensive care. And we'll talk a little bit about the importance of that, because one of the risks is, aside from not delivering appropriate prophylaxis, the other risk is not making the diagnosis until a catastrophic event such as a pulmonary embolus occurs. So if we talk a little bit about screening, this is a very interesting study that was conducted to look and see what was the value of ultrasound screening in a series of patients in a surgical ICU type setting. And what they did is they looked at patients that were going to be projected to be in the ICU for longer than 36 hours. And over a 24-month period, they were able to include nearly 300 patients in the study. And they found an incidence on ultrasound scanning of the lower limbs of major DVTs in the order of 7.5%. But what is really interesting is that they found that targeted screening was far more useful. So untargeted screening resulted in a relatively low incidence of DVT across the whole population. But when they decided to look at certain factors that made the use of ultrasound clinically more relevant, they were able to demonstrate that they could diagnose asymptomatic deep vein thrombosis with 95% sensitivity. And those factors And any one of the following three factors was relevant. One, if you had an Apache score of greater than 12, so in other words, how sick these patients were. Two, if your surgery that these patients were undergoing was emergent. And finally, if the patients were more senior or elderly and they used an age cutoff of 65 years. It was in this setting then that with any one of those screening criteria, only one of them, that they would then be able to decrease the number of ultrasounds they had to do by some 30%, but maintain that diagnostic sensitivity. So I think that's an important lesson, that if we're going to screen patients in the intensive care using ultrasound, it becomes important that you appropriately select the patients, and that is a useful strategy. We then look and see who should be doing this. And this is a very, very interesting piece of work conducted again in a surgical intensive care unit. Surgical intensive care units was a multi-center study conducted over 24 months, or an analysis of 24 months of data that was retrospective. And what they did is they looked at critical care physicians performing bedside compression ultrasound to detect or screen for deep vein thrombosis. And in this study, they were able to collect 128 patients, and the people or the physicians performing the bedside ultrasound in many cases had less than 2 years of experience with ultrasound. So in other words, the lesson there is that they didn't need a great deal of training in order to conduct this examination. And what they found in the study was an incidence, a relatively high incidence of deep vein thrombosis at around 20%. And the physicians, as opposed to radiologists or ultrasonographers, were able, with a sensitivity of 86% and a specificity of 96%, to diagnose with an accuracy, a diagnostic accuracy of 96%, the presence of a deep vein thrombosis. So that's very appealing for us in the intensive care, to say that you can wheel out the ultrasound machine, do a compression ultrasonographic examination of the lower limbs, and with a sensitivity of 86% and a specificity of 96% and an accuracy of 96%, diagnose those deep vein thromboses. The other thing that the authors of this publication made known was, by using bedside ultrasonography in the intensive care, they were very effectively able to reduce the time it took for that investigation. And they showed just short of 14 hours reduction in time to diagnosis by the critical care physicians undertaking those investigations. So moving away from screening now and looking at the effectiveness of the various strategies we have in place. And indeed, this study looked at the effectiveness of intermittent pneumatic compression devices for venothromboembolic prophylaxis in high-risk surgical patients. And it was a meta-analysis conducted looking at publications from 1995 through to 2014. They were able to include some 14 trials in the study, which amounted to more than 4,000 patients, so not insignificant. And interestingly, in this publication, they were able to demonstrate that intermittent pneumatic compression devices were comparable to anticoagulation for major clinical outcomes. And they hinted at the fact that perhaps a combination of intermittent pneumatic compression devices together with standard prophylactic chemotherapy would have some significant utility. Then early last year, this publication in the New England Journal of Medicine looked at the adjunctive intermittent pneumatic compression for venous thromboembolism. And what they did is that they randomized patients after 48 hours in the intensive care, and they were randomized, and to be honest, it was a significant number of patients. There were more than 2,000 patients, and they randomized them to receive intermittent pneumatic compression and standard chemoprophylaxis versus standard chemoprophylaxis. And the results were very interesting. As I mentioned, 2,000 patients, nearly 1,000 assigned to each group. And they were able to demonstrate that venous thromboembolism occurred in 10% of patients receiving pneumatic compression as well as anticoagulation, and in 9.4%, 10% pretty much, of the control group, which was just receiving standard anticoagulation. And death from any cause at 90 days was similar. And so therefore, the conclusion of that study was that there was potentially no advantage to the addition of pneumatic compression devices. I did say that we should spend some time looking at the chest guidelines, but I wouldn't mind taking the opportunity to just briefly look at this table that gives us some kind of indication of the value of the use, or the value in using a chemoprophylactic agent versus no agent at all, where you can see 13% versus 30%, and both in the CADE and the Kapur study, those numbers were very similar. It becomes less clear which is the preferable agent to use, whether we should be using unfractionated heparin, or indeed perhaps we should be thinking about using fractionated heparin. And in fact, the chest guidelines would recommend that in the context of trauma, we should indeed be using fractionated heparin in the form of enoxaparin or one of these such agents. The other thing that I think everybody in this audience has encountered at some point, to some degree, with some degree of concern, is the timing of pharmacological venous thromboembolism prophylaxis. So all of us have encountered a surgeon who's just done a laparotomy and says no chemoprophylaxis for 24 hours, or a spinal surgeon who says 46 hours or 96 hours, or indeed somebody that sustained a brain injury. And this was a very useful 2016 publication that I think is very illustrative of some important points. And what they did is they looked at more than 3,500 patients from the American College of Surgeons Quality Improvement Program that ran through from 2012 to 2014. And patients were effectively divided into early prophylaxis, and that being less than 72 hours, or late prophylaxis, that being greater than 72 hours. The patients were matched by propensity scoring to try to decrease the risk of selection bias. And the primary endpoint was venothromboembolic disease, and the secondary outcomes were defined as late neurosurgical intervention. And what they were trying to achieve here is that they were trying to look and see that if you, in essence, if you got early chemoprophylaxis, where you had greater risk of a subsequent neurological deterioration requiring intervention or resulting in death. And the results in many ways were extremely gratifying. Early prophylaxis was instituted in nearly 50% of the patients, which I, for one, wouldn't have guessed to be the case. Clearly, the patients who got later prophylaxis were those with more severe head injuries, those with intracranial hematomas, and those that had received early neurosurgery. The early prophylaxis was very interestingly associated with lower rates of both pulmonary embolism and deep vein thrombosis. And in a sense, that you'd expect. When I say interesting, it's fulfilling that this came to pass. What is fascinating is that early prophylaxis patients had no increased risk of late neurosurgical intervention or death. And so the message for me is very clear. In the early slides of this presentation, I've mounted an argument suggesting that venothromboembolic disease is a significant and severe problem in the critical care patient population. And this study would suggest that where we are fearful perhaps to institute venothromboembolic prophylaxis in the form of chemotherapy, we probably needn't be. And for me, the message there is that we need to be enthusiastic in terms of our institution of prophylactic therapy. I will just pause briefly here, and I've been very privileged as the president of the Australian New Zealand Intensive Care Society to be integral to our guidelines, and I'd like to express my gratitude to the Chinese colleagues who have been incredibly generous with their intellectual property and experience that they've developed, particularly through what must have been a dreadful time in Wuhan province in China. But COVID, as we all know, seems to be a disease that particularly affects the endothelium and the glycocalyx. And there seems to be an increased incidence of thrombotic complications, both venous and in fact arterial. And this has led us in our recommendations in Australia to suggest that if there's no overriding contraindication or significant concern with respect to generous use of prophylactic agents, we would strongly encourage this, and perhaps doubling the standard prophylactic dose to prevent those complications. And whilst we've had nothing like the experience of China, New York, Madrid, Paris, with respect to the COVID virus, we certainly have seen the presence of deep venous thrombosis in our patients and issues surrounding thrombus in COVID patients. So moving back to the surgical model or the trauma model, this is not an uncommon scenario that we encounter. What you're seeing here is a patient who was a fisherman. He was on the east coast of Australia, of one of the beautiful, beautiful islands, and I'd urge you all to come and visit sometime. It's absolutely spectacularly beautiful, white beach sands, beautiful ocean, and at times very remote. He was hit by a four-wheel drive motor vehicle and sustained a range of injuries, including significant frontal contusion, marked liver laceration, a significant pelvic fracture, shear force pelvic fracture, and bilateral lower limb compound fractures or open fractures, given the current terminology. Now, with these patients, this is precisely the balance that we have to deal with. We're dealing with the risk of bleeding in a patient like this, but we've also recognized that the subsequent risk of thrombosis and indeed subsequent pulmonary embolus with the very high mortality, 50%, that might carry, needs to be balanced, and we need to have a strategy. And if we look at the things that are available to us, it becomes somewhat depressing, if you like. In this patient with bilateral lower limb extremity fractures with external fixators placed to stabilize those fractures, the use of thromboembolic stockings is not feasible, as is the use of pneumatic compression devices not feasible. Given the frontal contusions and the ongoing potential risk from a liver laceration, and indeed the bilateral intercostal catheters that are in situ, it becomes very difficult to decide how best to prophylax in this instance. And the things that I've showed are just simply not options in that setting. So here comes the dilemma and the conundrum, which is decidedly interesting. And I think it's something that fascinates me. And I think this is a new frontier in medicine in many ways. Now, this will be familiar to many of you as a IVC or an inferior vena cava filter, and there's a whole range of them. But the notion is that the filter is placed venously or transcutaneously into the venous system, either via the jugular vein or via the femoral vein, and the filter is deployed in an infrarenal position in the inferior vena cava. And the concept here is that any deep vein thrombosis that subsequently forms in the lower limbs and embolizes will be caught in the filter and not result in a pulmonary embolus. And when one looks at that intrinsically and intuitively, it seems like a brilliant idea, but it's not entirely clear as to the value of the system. And part of that confusion has been a function of the wide range of types of filters that have been available and the generations of filters that have developed. So now we find ourselves in an era of filters that are much more easily retrievable, and so some of the risk can be ameliorated, and filters that are potentially more effective and less likely to generate thrombus in their own right, distal to the filter. Now, how we put these filters in my institution, it's performed by radiologists using fluoroscopic guidance. But very excitingly, there's a huge body of evidence that's now suggesting these filters can be put in at the bedside with an intensivist using ultrasound to guide the positioning of that filter. And that's not surprising. I mean, the IVC is a large structure. The renal veins are easily visualized. And so the target of where you're trying to locate the filter is relatively easily achieved. And so there's a mounting body of evidence to say that this is a safe, cost-effective approach to the positioning of filters. Filters, of course, are not without their risk, and certainly they've been linked to very significant injuries. If one looks at the CT scan, what you see there is an IVC filter that's in fact tilted on itself within the inferior vena cava. And the tilting of a filter such as this then generates the risk, in fact, increases the subsequent risk of thrombus development. It becomes ineffectual and indeed runs the risk of damaging the IVC. This coronal section, CT scan, very clearly demonstrates, I don't know if you can see my pointer, very clearly demonstrates the filter sitting probably in the wrong position there in relation to the renal vessels, and distal to that is significant thrombosis, which has always been the fear and the potential risk or concerns with respect to the position of a filter. Even more concerning is this transverse CT section that demonstrates the arms of an IVC filter sitting within the lumen of the inferior vena cava. But on closer inspection, you find that one of those arms has in fact breached the wall of the inferior vena cava and is impinging on the wall of the aorta. And there have been a good number of case series of reports of aortic perforation, IVC perforation, and indeed rather fascinating that some of these filters have been found free floating in the peritoneal cavity, where somehow or another the IVC has repaired itself and the filter has migrated into the peritoneal cavity, which is quite remarkable. In 2010, the FDA issued warnings, and the warnings around that were principally, if you're responsible for putting a filter into a patient, you better make sure that you get the filter out when the patient no longer needs it. And I think up until that point, we'd been relatively poor at ensuring that filters came out. I know in our own institution, we lost several patients to follow up until the system was more rigorously controlled. And now I'm happy to report every single patient is followed and aggressively has their filter removed. We do know that the FDA reported that there literally are thousands of cases that have been brought forward in the form of legal action, with the three main companies producing IVC filters currently still facing significant litigation. So looking at an apparatus or a device that potentially carries substantial risk, the next question we have to be asking of ourselves is, how effective are prophylactic inferior vena cavas? And this particular systematic review looked at trauma patients and asked the question, how useful is the insertion of this device that could potentially be harmful turn out to be? And if you look at this forest plot, this is figure 2 in their publication, and it's the relative risk of a pulmonary embolism in the setting of an IVC filter versus no IVC filter. And on the left-hand side there, you'll see that it favors therapy with an IVC filter. And the trend is very definitely to suggest that an IVC filter is beneficial, noting that the confidence intervals cross the midline. Similarly, and perhaps more impressively, is the relative risk of a fatal pulmonary embolism in the setting of IVC filter use versus no IVC filter. And similarly, there would appear to be a benefit to the use of IVC filters. But when one looks at what the study demonstrated, the number needed to treat might be as high as 1,000 patients in order to prevent one fatal pulmonary embolism. And so that really begged the question, is this a strategy we should be using? Not to mention that it's expensive and relatively complex. The authors concluded that the strength of evidence was low, but it supported the association of IVC filter placement with a lower incidence of pulmonary embolus and indeed fatal pulmonary embolus in trauma patients. Probably the key sentence at the conclusion of this meta-analysis was, additional well-designed observational or prospective cohort studies may be informative. And this piece of work published in JAMA in 2014 also stirred up some significant debate. And this table, I just put it up. If you look at it, it's a series of columns that says the indication, the society that supports the indication, and the societies that oppose the indication. And it becomes apparent that oftentimes it's the radiological societies that are pro-insertion of an IVC filter, and perhaps less so some of the other organizations. But when you come to trauma, there's an absolute dipolar or polar opinion as to what should be done. Should we be inserting these filters in the high-risk patients? And the radiology groups would suggest yes, while the chest physicians would suggest no. And I think that's a reasonably compelling argument for us to go and study it. And this was our group. This was our BMJ open access protocol publication, where we set about to try to tease out, would an IVC filter provide benefit as prophylaxis to trauma patients who were unlikely or couldn't receive standard anticoagulant therapy for the first 72 hours. So there's not an uncommon scenario. Patients come in, had a motor vehicle accident, got a head injury, got a lacerated spleen, not dissimilar to the case I presented. Everybody's a little bit concerned about providing deep vein thrombosis therapy in this setting. And so the question is, should these patients automatically get a filter as a modality of prophylaxis. And so we published our study protocol in the BMJ, and I think this might have been in 2017 or, 2017. And we went on to be very fortunate to publish our work in a the New England Journal of Medicine, following our multi-center trial of vena cava filters in severely injured patients. And the results were fascinating. So for those groups of patients who couldn't receive standard chemoprophylaxis for the first 72 hours, the insertion of a filter conferred no benefit at all. There was no value to inserting a filter. If you look at the secondary endpoints in our study, that was very interesting. So symptomatic pulmonary embolism from day 8 to day 9 in patients who did not receive prophylactic anticoagulation within the first 7 days after injury. So that's a significant number of patients that potentially happens to you. And in this setting, in the vena cava filter group, there were 46 patients that, in other words, fulfilled that of not surviving beyond 7 days and not receiving anticoagulation. And none of those patients went on to develop a pulmonary embolus. Compared to the control group, who didn't have the IVC filter, who went on to survive more than 7 days, and who didn't receive anticoagulation for those 7 days, it becomes apparent that 5 of 34 of those patients, 14.7%, went on to develop a pulmonary embolus. So that would be very suggestive that there might be benefit in the use of an IVC filter in this group. So I think it's a absolutely fascinating area, a challenging area, and despite being a common problem in our critical care patients, we still do not have all of the answers with respect to which agents we should be using, which strategies we should be using, how we should be screening, when we should be screening. Suffice it to say, everybody that's tuned in tonight or is on this webinar, going back to their intensive cares tomorrow morning to do work, I would urge you to think very carefully about the risk of deep vein thrombosis and subsequent pulmonary embolus to our patients. And we should continue to aggressively search for these thrombi and indeed aggressively institute strategies to prevent it happening. And most of all, we need to study the problem more. So with that, I would, with a lot of gratitude, like to thank you all for your attention. I would like to thank Xiaoting for the kind invitation to present at this meeting, and really hope that people out there that have taken the time to sign in or register for this meeting have found it beneficial. So thank you very much to all of you.
Just now, Dr. Hong take a great lecture about the DVT and the PE, how to prevent and how to prophylaxis, and give us lots of knowledge about DVT and the PE. So I think I can see lots of good ideas from the lecture. So I try to give some summarizing about Dr. Holley's lecture. I can know lots of key points from his great lecture. Just in the very beginning, he give us algorithm, maybe a protocol for how to prevent and prophylaxis of DVT and PE. In my opinion, maybe in the Dr. Holley's opinion, it's ultrasound screening in the very beginning, maybe in the total total proceeding of the trauma patients. Maybe ultrasound to screen the DVT is very important, but maybe there's some other ideas. Maybe after a while, we wait a minute, and Dr. Holley give us maybe other ideas about the ultrasound screening DVT. It's very important. It's the key point 1, and the key point number 2 about the lots of measures. There's lots of measures to prevent the DVT and the PE. Maybe the first one is intermittent pneumothoracic compression. It's a great idea about the DVT and the PE prophylaxis. It's a key point 2, and then there's the key point 3 about the pharmacologic to prevent and to prophylaxis of DVT and the PE, especially maybe the severe PE. So like how to select the drugs, maybe the LMWH and maybe the UFH, the different heparin, and maybe which time, what's the exact timing to use the drugs to prevent the DVT and the PE. And then there's a key point about maybe the fourth key point about IVC filters. Dr. Holley give us lots of important ideas about this, just like how to use ultrasound to guide the placement of the IVC filter, how to use the CT scan to find the exact place of the filters, IVC filters, and then give us lots of warning, especially come from FDA warning, and then give us lots of papers, give us exact ideas about the IVC filters, to how to select the time to place, and maybe it's have lots of useful, maybe no use. I think it's a very great lecture about the DVT and the PE prophylaxis. Let's say thanks again for the Dr. Holley. Thank you.
Thank you very much, Professor Wang. Much appreciated. Thank you.
Yeah, thank you. Thank you, Dr. Lanz, for your in-depth, maybe the great lecture about the DVT and the PE. And then let's move on to the Q&A section. Maybe I can some I think a question from the center room. There's two questions. Every question is for you. The number one is maybe Mr. Paul Jared said it's a very nice speech. May I have a question? How do you rule out the DVT among patients who contain the COVID-19? It's a great question. Maybe it's your turn. Thank you.
Thank you very much, Professor Wang, and thank you very much for that question. I think the principle is the same as it is for any other critically unwell patient, except perhaps because of the nature of the illness, and I feel embarrassed talking about it when I'm talking to people that have seen probably way more COVID than what we've seen here in Australia, and indeed, I'm not sure where the question came from. If it, I'm just looking at it's Purcell Gerard. I'm not sure if that's French or where that physician is from. But look, I think it's one of those conditions that you need a low index of suspicion, and so I think you'd be better off looking for it if you had any concerns. And perhaps regular screening. The experience that we've had with the COVID patients is that they've stayed for long time. And obviously that increases their risk length of stay. These patients have been proned, they've been sedated, they've undergone neuromuscular blockade, and they have a gross inflammatory situation such that they really are at risk. So I would have thought you need a low threshold to evaluate them. And then you're challenged by the fact that you don't want to be taking these patients through the hospital. So you want point of care testing. And so in that setting, I think ultrasound is easily achieved, and it's easily achieved in their cubicle or in their bed space, and can provide that valuable information. And to that end, I would have thought it's not unreasonable to electively screen these patients, certainly be aware of the heightened risk. And I think if you have any concerns, you're better off looking for it than not.
Mm-hmm.
I have, hopefully that answers that question.
Yeah. As we all know, the DVT and P is a important cause of death of COVID-19 patients, especially from the recently published paper from the New England Journal of Medicine, from a pathologic paper.
Yes.
Maybe only six patients. There's maybe I think in his paper tell us there's 1/3 patients died, and the main reason is DVT is a pulmonary embolism. So I think this question is very important about how to use ultrasound to screen the DVT of the COVID-19. The frequencies, maybe the every day. How do you think?
So look, I'm not sure that every day would be useful, and it's time consuming. So I would have thought it's something, that unless you had a particular suspicion in a patient with a swollen limb or something along those lines, perhaps every 5 or 7 days would be a reasonable interval to look. And if you saw something worrying, then perhaps more frequently would be my mindset. So we don't have a set protocol. We just use it on clinical acumen. And if there's a concern, we'll do it. But we're mindful of the potential resource limitation. In our institution, we all do ultrasound ourselves, predominantly in terms of guiding insertion of central venous catheters and the like. Some of us are comfortable doing compression of veins, looking for deep vein thrombosis. But we also have sonographers that can come up to the unit and perform that function. And that's also valuable, because if the critical care physicians are tied up doing something else, a sonographer can come through the unit and evaluate a number of patients very easily. And quite frankly, they're quicker than we are.
I totally agree with you. Just what you mentioned about the ultrasound, using ultrasound to screening the DVT, about the frequency and especially frequencies. Maybe from your opinion, I can acquire important information about the worrying about the DVT. So the maybe a strong worry about the DVT. Maybe we using ultrasound to screening the DVT, and the frequency is very often.
Yeah, I think we're very lucky now, because it's a non-invasive test.
Mm-hmm.
Yeah,
Okay.
I think we're very lucky. It's non-invasive. I showed you some of those studies. It's, even in the hands of people that are not expert, it's got a 95% accuracy. And we've kind of moved away from the old previous gold standard, which used to be the venogram. People can hardly even imagine doing a venogram. I don't know when I've seen a venogram. Maybe when I was an intern was the last time I saw a venogram, because now it's so easy at the bedside to do that examination. Now, obviously, the morphology of the patient, if you've got somebody that's morbidly obese, it makes it more challenging, and nothing is perfect, but it is still very, very useful. And in fact, the technology advances that we've got now has also changed things. You know, we've got duplex and you've got color. You can put color across things. There's a whole range of things, and an ability to save the images and save the recordings. So, but the actual frequency that we should be screening, I'm not sure that a daily, we certainly don't do daily screening because that would be very demanding time-wise. But certainly when you think it's clinically indicated and when you have a high suspicion, I think because it's non-invasive, relatively easily done, it's a useful investigation.
Yeah. So anytime if we have a little suspicion, we need to screening for the DVT every time. Thank you. It's a good answer. Maybe it's very interesting. And then there's a second question about IVC filter. How about the pros and cons of the IVC filter? How to select the patients? Thank you.
Yes, I think selection of the patients is incredibly difficult. I think the use of IVC filters in patients that have an absolute contraindication to anticoagulation and they have lower limb deep venous thrombosis, I think those patients you have a solid indication. Similarly, patients who have got lower limb DVT, deep vein thrombosis, and have failed, what we term failed, anticoagulation therapy by virtue of having had a hemorrhage or a complication such that we can't proceed with that therapy again. I think those are clear cases for the insertion of a filter. What becomes a little less clear are those patients with pre-existing cardiac disease or pulmonary disease where you feel that they will ill tolerate a further embolic episode. So where somebody has a compromised myocardium, they have a deep venous thrombosis burden, and you know that if they were to further embolize, they would probably die. That's a group of patients that I think might well benefit from an IVC insertion. Mm-hmm. When we're talking pure prophylaxis, our own New England Journal study suggested that in people that had sustained severe trauma, mm-hmm. and the injury severity score in those patients was greater than 15, even in patients who couldn't be anticoagulated for 7 days, there wasn't a benefit to filter insertion in terms of pulmonary embolus. But in patients that didn't get anticoagulation and then went on to survive beyond 8 to 90 days, there appeared to be an advantage to those patients. So I think we're still uncertain and we're still unclear, and it'll be a case of as the filters get safer, the technology surrounding their insertion is safer, the technology surrounding their removal is safer, then I think when we get to that point, we'll be in a position to better choose which patients receive a filter or not for pure prophylaxis.
Mm-hmm. Maybe you can give some key points about your recommendation about the high-risk patients, how to select the patients have the high risk, the key points, maybe one by one.
Yeah, so I think the key points surrounding patient selection, I think is the one that I'm pretty definitive on for an IVC filter is if you have a clot burden and can't be anticoagulated. That'll be point one. So you just can't be anticoagulated, just had spinal surgery, massive spinal surgery, or you've had some significant bleed, etc., then I think that's a clear indication. I think in the next group is if you've failed anticoagulation. So it's very similar to the first group, but you've actually had a trial of anticoagulation and for whatever reason it is, have been unable to tolerate that anticoagulation, then that group of patients, I think in the presence of clot burden in their lower limbs would benefit or potentially benefit from an IVC. And I think an IVC filter. And I think it's in that setting that it's the safety of insertion using the appropriate technology to get it in place, and equally important to get it out. And I think that's one of the mistakes we've made, is that we've not been as vigilant as we should have in terms of getting the IVC filter out of patients. So I think those are clear-cut groups. And then the third group, Professor Wang, I think is that group of patients where you're aware they've got a clot burden and their physiology is poor, such that they perhaps wouldn't tolerate another embolic event. And I think there the risk-benefit ratio might favor the insertion of a filter versus the ongoing risk to those patients. Hopefully that reiterates my thoughts in terms of the key points in terms of selection of patients.
Thank you for your great recommendation about the DVT prophylaxis. I think maybe because COVID-19, especially critical COVID-19 patients, maybe everyone have the opportunity to be placed the IVC filters.
Yeah, I think that would be yeah, I mean, it's an interesting thought, but my first instinct would be no. I think because we know the risks of filter insertion, both at insertion time, of maintenance and filter, and we're not entirely certain of the benefit, I think we would be well placed to be much more selective about the patients that we chose to put a filter in, rather than just on the disease basis. So I think it would be the presence of clot, the inability to anticoagulate them, and perhaps some other risk factors that would drive us in that direction to do that. But it's an interesting point you raise in a disease that we know has been associated with significant thrombosis, both arterial and venous.
As what you mentioned about the IVC filters, about the critical COVID-19 patients, maybe in the very beginning, screening the IVC, screening the IVC and screening the DVT is very important. Maybe in the early phase.
Yeah, I think you hit the nail on the head. And I would just like to premise this. I'm certain, Professor Wang, that you've seen more COVID patients than what I've seen. I'm absolutely certain, given the burden of disease your country's experienced. But I think that much more valuable would be the screening of COVID-19 patients rather than prophylactically putting a filter. I think much more utility would come out of saying, look, this is a high-risk patient. Let's use a non-invasive, relatively cheap, highly specific, relatively sensitive, high diagnostic accuracy tool to look and see. And then that way we wouldn't have to subject patients to an invasive procedure without benefit. So that would be my take on it, that you'd be better off looking to see they don't have a clot burden or a thrombosis burden, and not even thinking about a filter in that group of patients.
Thank you. It's a good answer. There's another question, maybe the last one. Do you have any difficulties in using ultrasound to screen DVT patients? As you know, in China, there's lots of ICU doctors can performing ultrasound to pay more to monitoring the patient's heart and lung, and but it's very rigorous. There's no routines regulation about DVT screening using IVC, using ultrasound screening for IVC for DVT. So how about your hospital? How about your practice in ICU?
Yes, so I can talk to that. We don't have a set protocol. We don't have a set protocol. It's clinician or physician consultant driven. You make the decision based on a case basis. The first part of your question is, do we have difficulty? And the short answer is no, because we've got a very, we're very well serviced by a very productive radiology department with lots of sonographers. So we're inclined to get a little bit lazy because it's that easy to pick up the phone and fill in the form, and somebody else can spend the 30 minutes doing the investigation, which is non-invasive, cause your patient no harm, and you can get the result. As I mentioned partway through my presentation, that a good number of us use ultrasound in our day-to-day practice, be it for, high-end things like ECMO cannulation, percutaneous ECMO cannulation, renal replacement therapy, catheter insertion, or central line insertion, PICC line insertion, and in some cases, arterial line insertion. And I think it would be, I can't speak for every single Australian intensivist, but I think most of us would be very comfortable with those indications, because it's a real-time procedure that can provide you with guidance as you do something. And to be honest, Professor Wang, I'm often mystified that my first few years as an intensive care trainee, we didn't use ultrasound. We used to use landmarks to insert central venous catheters, and I'm somewhat astounded that we didn't have more catastrophes, given how often the anatomy varies. So I think from an intensive care perspective, all of us are very comfortable with those indications. When it comes to, a 4-limb DVT scan, there's a time component there that oftentimes we're time poor and can't do it. But indeed, there's also the expertise that's required. And it's one of those things that I showed you that study where they were able to demonstrate that point of care testing with people that had used ultrasound for less than 2 years in a surgical ICU setting, they were able to diagnose with a sensitivity of 86%, a specificity of 96%, and a diagnostic accuracy of 95%. So I think it's very achievable, but we've just got to get off our butts and do it. It's much easier to pick up the phone and call for the investigation.
Yeah. Thank you for your good answer about this question. It's a difficult question, but you can answer this question very, very correct and very, very good. And then maybe would you like to give us three important sentence about your lecture, today's lecture? 3 sentences.
Yeah, I think DVT is an under-recognized problem. It's point 2, it's an under-treated problem. And point 3, I think rather than being as cautious as we are, we should be more aggressive in preventing deep vein thrombosis. And if I'm allowed one more point, Professor, I think you need to be mindful of the patient population you're dealing with to stratify the significant risk for those patients.
Thank you. Maybe I think these 3 sentences have lots of chance to become the famous thing about the PE and DVT prophylaxis in ICU, in critical care, in the sickest ICU patients. Thank you.
Thank you very much.
So maybe so much for today. It's maybe Forrest Chen give us some your opinion about today's lecture, today's theme, and then terminate today's lecture, today's theme. Thank you.
Thank you very much, Professor Wang. Thank you very much. Thank you, sir.
Okay.
Thank you.
Let's say thanks again to Dr. Holley and Professor Xiaoting Wang. And also many thanks to all audience who are with us today. It's time to say goodbye. and wish you all have a nice day. Please follow Visoni Facebook and LinkedIn for more webinars in the coming days. Bye-bye.
Bye-bye.
Thank you very much, Forrest.
Yeah.
Thank you very much, everybody.
See you. Okay, bye.
Good night. Thank you very much, everybody.
Yeah, come
Charlie,
on.
for all of the help with the technology.
谢谢王教授
Thank you,
谢谢王主任
Good night, Professor. Thank you.
非常感谢 Thank you very much
Thank you.